I guess the important thing is to start with this slide. And when Paul and I sat down to talk about the length of the donation pathway, the first thing I'm going to really say is we've heard it mentioned all morning that the pathway and the length of time taken to facilitate donation is getting longer across the piece. And there is absolutely no question about that. But I think what's more important is that we talk about, and we will talk about this towards the end, is doing key things at the right time and at the appropriate time. Paul mentioned that we used to do retrieval in the night time. Well, we've seen a complete flip in that to retrieval during the daytime, and that's not good for any of you sat here. But essentially, this slide does reflect that we are all busier. From specialist nurses, recipient coordinators, NORS retrieval, transplant teams, everybody is busier, end of. There is no question. This year we celebrate 10 years of the Organ Donor Task Force, and Paul, my co-pilot for today, was instrumental in all of that. I think we should acknowledge, so the data is slightly different to what the stats team presented this morning, is that we have seen a 92% increase in donation rates since the start of the task force and a 67% increase in transplant numbers. So actually, yes, things are getting longer and it's taking longer, but we have to see the good news story in a sense that we are transplanting more patients. So I'd like to take it back a little bit. There's no need for me to stand here and tell everybody involved in retrieval and transplantation that you're busy. You all feel it every day. But I'd like to take you back to actually what happens in the last 3 years, what has been happening in terms of referral to the specialist nurses. And I'll just look at last year's data. We can see that the specialist nurses had over 1,700 patients referred to them, potential DBD patients. They're attending over 1,600 of these patients. Over 1,300 times those families were approached to yield 829 DBD donors, transplanting over 2,700 patients. So actually we can see straight away that activity is much higher than we've actually ever seen before. And nobody is knocking this. We want to transplant more patients, but actually it's having a significant impact on everybody. Now this is the same slide, but highlighted in red, DCD. Because I think it's really important for me to actually illustrate to you is the DCD referrals to the specialist nurses and the increases that we've seen. The increased SNOD attendances, increased actual donors, and increase in the organs transplanted. Of course, what it really does not illustrate is actually the DCD stand downs. So it's the NORS retrieval activity that the NORS teams go out and wait 3 hours and then stand down and return home again. So it actually doesn't really reflect all that activity. So I guess what the last 2 or 3 slides have shown is that we are undoubtedly all busier. So is it something happening in the intensive care unit that's lengthening the pathway? We do know, and we've seen already this morning, that the age of deceased donors in the UK has undoubtedly started to increase. With an increasing BMI of the deceased donor pool in the UK, undoubtedly some of the donors that we go out to assess may be classed as more marginal than we were accustomed to 5, 10 years ago. Additionally, it does take a little longer sometimes to do a thorough patient assessment and donor characterisation of these patients. So things have changed from the intensive care perspective. We would actively encourage, and Paul and Dale know that we actively encourage early referral to the specialist nurses. The earlier they're there, the quicker and the more efficient we can be in the process. But we know, and we've heard from Paul this morning, that significant delays of these patients in the intensive care unit is burdensome in terms of ICU bed capacity. Paul and I looked last week at a lot of data, as you can imagine, and we thought it was really important to actually show and to reflect to you and ask the question, so has the donor profile had a change on the average number of organs donated? We had a question this morning, an interesting question raised by somebody in the audience of another speaker about the increase in DBD donors that we've seen, particularly last year, and we will see it again this year. And we believe that actually it may be attributable to the increased 4 or 5-fold increase in hypoxic brainstem death after hypoxic brain injury, which may in turn be attributable to the slight reduction we're seeing in the average organs donated per DBD donor. However, on the other side, we're seeing the opposite in DCD, increase in DCD numbers, an increase in the number of organs donated and subsequently transplanted. So is offering the problem? Can we say that organ offering and organ allocation is the key problem to this? In fact, I would say that there is no one particular area, an element of the pathway that is a problem. We looked at offers per DBD donor, and rather reassuringly, in the last 6 years, we haven't seen a significant change in the median numbers of offers of kidneys from kidney offers to acceptance. This has remained really relatively static over the last 6 years. However, the change we have seen is in offers per DBD for heart donors. And I'm sure Professor Dark is somewhere in the room and will be looking at this very closely. What we can see from this slide is that the number of offers for heart donors, the median has increased in the last couple of years. My learned stats colleagues, we had lots of discussions about this over the last couple of months, and we feel that this is attributable not just to the change in profile of donors, but also the changes that we see in the super urgent and urgent heart offering schemes. What I mean by that is, as of yesterday morning at 9 a.m, there were 45 urgent and super urgent heart patients waiting for transplant in the UK, whereas 5 years ago, there was maybe 5, 6 urgent heart patients. So we are seeing, as we've seen in a lot of talks this morning, a complete change in the patients waiting for transplantation. I'm not going to dwell on this slide because Paul has gone through the length of the pathway, but more importantly, I'll quickly go to the next part of the slide. We wanted to look at and present you the data today in terms of, is the length of the pathway, does it increase when cardiothoracic organs are offered? Undoubtedly, yes, it does increase from 42 to 56 hours, lengthening the overall process of 14 hours when cardiothoracic organs are offered. A significant period of time for the process to be lengthened. But those involved in abdominal transplant centres, sorry, going on a little bit too far. This process has also lengthened as well. So when we're offering abdominal-only organs, we still have seen a lengthening of the process, a lengthening of the pathway. So it's 9 hours longer we have observed when cardiothoracic organs are not being offered. So the process has lengthened, irrespective of cardiothoracic offering or not. So Paul has given me the unenviable task about talking about the solutions and how we get ourselves out of this. I will say it again, it's essentially about how we do elements of this pathway at the most appropriate time for healthcare professionals, for patients and for families. Earlier in 2017, we held a multi-stakeholder workshop looking at this problem and we tried to engage with a number of you who are here in the room today about how best to achieve solutions to reduce the length of the pathway. We have implemented many of those solutions, and suffice it to say, we haven't seen a huge impact on reducing the time from patient referral to transplantation. I'm going to go through the next couple of slides and talk to you about what we have done and what the next steps are. You will always hear us talking about early referral to the specialist nurses so that they can get on and do their work and make a rapid assessment on the intensive care unit. We have talked about expediting the process in asking the donor hospitals to do some preparatory work for us. We have a pilot going on in the Midlands team, and that involves having a checklist for ICU staff so they can get on and do some of the preparatory work for the specialist nurses. Having all the medical notes there, the GP notes, because all of this can be cumbersome when the SNOD arrives if we're waiting to get notes from other hospitals. Okay. early blood sampling and dispatching, all regions, prompt diagnosis, early diagnosis of brainstem death, withdrawal of care in theatre, another pilot in the South Central, and review of SNOD handover times. What we would like to do is really stick to the maximum time of 45-minute times for organ offering, and we will be able to do that with the IT technology very soon. Standard method of contacting recipient coordinators. This is still work in progress because we, as you will know, Vodafone and the loss of pagers coming soon. We heard about the new cardiothoracic offering protocols that is now in place, and we also have reviewed our kidney allocation policy so that we can mobilise teams quicker. Standardising of fast-track policies. This is working going with our statistics teams, and this is going to be very, very important in giving the right information to centres about why organs have been declined. Automated simultaneous offering for microbiology and enhanced EOS functionality. So in terms of retrieval, I'm not going to go through them all in the interest of time, or Rachel will probably ask me to leave the stage, but these are kind of the actions that we are working through currently. Next steps, and this is probably the most important thing that we want to look at, is that we have heard about changes to lots of allocation policies. We have arranged another smaller stakeholder meeting to look at the metrics. Chris mentioned this morning, if we don't have the metrics, then we can't do anything to improve it. Essentially, what we want to do is break down each component of the pathway and look at sensible ways of measuring it, but importantly, sensible solutions of how we're going to redress the balance. Before I hand over to Paul to give the final remarks on this topic, I really want to thank colleagues in the stats team. They all know who they are, and one or two of them aren't here today because they have been really so incredibly helpful with providing all the stats to both myself and Paul. Thank you.